Hello, everyone. Welcome to the universe of cardiology again. This is Dr. Jaitly. Here I'm going to be talking to you about, very briefly, uh, what is abdominal aortic aneurysm and some of the very important facts that we know about it. Now, a lot of things in medicine we still don't know. I always say that we're approaching like the shores of an ocean, and we don't know what the volume of the water that's contained, or the body of the water that we are getting into. So it's like we have come to a great understanding about various processes in medicine. However, it's still, as I say, a drop in the ocean. Anyway, so abdominal aortic aneurysms affect predominantly the males past the age of 65, and the common denominators that we have come across are that they are smokers. In general, smoking has become the strongest predictor of an abdominal aortic aneurysm past the age of certain 65 to 70 years of age groups, and it's prevalent in 5% of the people. Now, most of the time, it's not detected because it stays asymptomatic, or it's an incidental finding that the physician during an examination suggests, and say an ultrasound or maybe a CAT scan or MRI that was being ordered for other reasons perhaps, or even as a screening mechanism now that's recommended by the US Task Force of American College of Cardiology, that past the age of 65 being a male smoker, at least one examination by an ultrasound is recommended to screen as a part of a screening mechanism. Nevertheless, it does present as symptomatic, but then in that case, it's already an aneurysm which is starting to show some complications, whether it's a dull pain, abdominal pain, or pain radiating to the back, for instance, or if it's a mass, or if it's a pulsatile abdominal mass. Now, that may be an indicator that an ultrasound or a technique could be done. Now, CT and MRIs, of course, will actually accurately determine the dimension of the aneurysm. So, by definition, let's try to define what an aneurysm is. So, 2 to 3 centimeters is the normal size of an abdominal aortic aneurysm, as I've shown here in the left panel. So the dimensions are very clear, 2 to 3 centimeters. Most people have 2.5 centimeters as abdominal aortic aneurysm. Now, it starts dilating slowly. The smaller the aneurysm, the slower is the increase or rate of change of growth. Now, as the aneurysm grows in size, it gets 3.5 and 4, or 4.2 and 4.5, and so on and so forth. The rate of change per year, if you were to look at by any imaging techniques, will be faster. So it is very important to know that smaller aneurysms grow slower, bigger aneurysms grow faster. Obviously, the larger the aneurysm, the greater the chance of it rupturing or dissecting. So there is a cutoff, obviously. There is a recommendation that's by ACC and by the American Thoracic Surgeons Society that one should look at certain sizes, and beyond certain size, or the rate of change, if it's occurring very rapidly, then also one should recommend surgery, because it's a surgical really repair that's going to prevent any further complications. Because once the dissection occurs, so once the rupture occurs, and the mortality is very high, obviously, unfortunately, it's more than 80%, even in the best of the best hands and the best of the best centers. So let's see now, if it's less than 5 centimeters, then you're looking at a mortality of 5% or less per year. But as each 1 centimeter increases, in the dimensions of the abdominal aortic aneurysm, let's say it's going from 4 to 5, that's in 1 centimeter increment, the mortality will rise by 10%. So say it was 5% then, and now it's 15%. So here are some of the magic points that I just want you guys to remember, so this way, even for the boards, the exams, or just general knowledge proliferation and extension or dissemination of the knowledge, one can ascertain that. So each 1 centimeter will raise the mortality by 10%. As smaller the growth, as I said, the lesser is the rate of change, but the larger the growth, the larger the size of the aneurysm, the faster it grows. So abdominal aortic aneurysm, which is also called as a AAA, less than 4 centimeters will grow about 0.2 centimeters per year. Whereas now look at this, 4.5 centimeters will grow at a rate of 0.35 centimeters per year. Pretty impressive. So as even a 0.5 centimeter change within the abdominal aortic aneurysm dimension will impede the growth of the abdominal aortic aneurysm by increment of this magnitude from 0.2 to 0.35 centimeters per year. So the management, obviously beta blockers have been there for a long time because they slow the heart rate, they slow the shear force across, and that was also, as you know, was recommended, as I've shown on the thoracic aneurysms here, if you recall on my other videotape. I've just put this as a comparison because you can have ascending aorta aneurysm, arch aneurysms, and then of course descending aorta is here. So you could have dissections everywhere happening within this thoracic aneurysms. But that is just a comparison. Coming back to the AAA, the management is again beta blockers. Statins have been shown to prevent, regression of or prevent atherosclerosis or regression of atherosclerosis, if you will, because as I said, the other risk factors could be atherosclerosis and hypertension. Sometimes we don't know the cause, but smokers is in general. Now, women are less affected. It's very important. Women are less affected, but men are more affected in this. ACE inhibitors are good because it seems like it's not just the rate of change of expansion alone, which is controlled by beta blockers, but seems like ACE works on the matrix of the abdominal aortic aneurysm texture or the wall itself. So ACE inhibitors, there have been some clinical trials that these triple therapy of beta blockers, statins, and ACE inhibitors in this AAA works. Okay. Surgery is obviously the answer, but one sees surgery is either an open heart, not an open heart, but an open abdominal aortic aneurysm, or it's a graft, which is an endovascular graft, which is placed in. Now, it comes in complications, obviously, because it's a foreign body that you're trying to implant within the abdominal aortic area. So it's not totally free of risk from complications. Plus, the post-op care is much bigger, much intense than the open variety, where you actually resect the aneurysm, take this aneurysm out, and the aneurysm. But that works mostly for shorter aneurysm. But if it's a larger aneurysm, one has to give an endovascular closed graft. Hope all of this was helpful, and as I said, again, please go ahead and supplement more knowledge and information from the textbooks, articles, and journals, and keep tuning in to my series of video presentations on heart and cardiovascular. Thank you again for your attention. Appreciate it.